Cardiomyopathy translates to heart muscle disease. So cardiomyopathy is a broad term used to describe a variety of issues that result from disease of the myocardium, or heart muscle. When cardiomyopathy develops as a way to compensate for some other underlying disease like hypertension or valve diseases, it's called secondary cardiomyopathy. But when it develops all by itself, it's called primary cardiomyopathy. Now, the most common type is dilated cardiomyopathy, which can cause all four chambers of the heart to dilate, or get bigger. Specifically, new sarcomeres or muscle units in the walls are added in series, and the chambers grow larger, which leaves the walls relatively thin compared to the large chamber size, with less muscle to use for contraction. In other words, they have really weak contractions, which means less blood gets pumped out with each contraction, meaning there's a lower stroke volume. And if the heart's failing to pump out as much blood to both the body from the left ventricle and the lungs from the right ventricle, patients develop biventricular congestive heart failure. And since contraction happens during systole, we say that this is a type of systolic heart failure. Also, when the chambers get larger, they tend to stretch out the valves that separate the atria and the ventricles. When stretched, the valves can't close all the way, so they start to regurgitate blood back into the atria, called mitral valve regurgitation on the left side and tricuspid valve regurgitation on the right. The former of which might be heard on auscultation as a hollow systolic murmur, meaning that it happens throughout systole. In addition to that, you might also hear an S3 sound, which is the result of blood rushing into and slamming into the dilated ventricular wall during diastole. Arrhythmias can also be a complication, because stretching out that muscle wall can irritate the cells in the conduction system, which are within those walls. Sometimes an X-ray can be helpful for diagnosing dilated cardiomyopathy. As far as causes go, most of the time primary dilated cardiomyopathy is idiopathic, meaning there isn't a clearly identifiable cause. Some cases, though, can be traced back to specific genetic mutations, or genetic conditions like Duchenne muscular dystrophy and hemochromatosis. Also, in some cases, it could be caused by an infection, like Coxsackie virus B, which causes myocarditis, inflammation of the heart muscle, or Chagas disease, a protozoal infection. Also, alcohol abuse is strongly linked to dilated cardiomyopathy, since alcohol and its metabolites have a direct toxic effect on the myocardium. Similarly, certain drugs can also be a cause, including chemotherapy drugs like doxorubicin and daunorubicin, but also drugs like cocaine. Also, wet beriberi, which is having too little vitamin B1, aka thiamine, can lead to dilated cardiomyopathy. Peripartum cardiomyopathy is an important cause as well, where dilated cardiomyopathy can develop in the third trimester of pregnancy or in the weeks following delivery, probably because of issues like pregnancy-associated hypertension, although about half of patients recover following pregnancy. As you can see, there are a lot of things that can lead to dilated cardiomyopathy, and regardless of the cause, the outcome is less effective systolic function. Treatment for severe dilated cardiomyopathy can include a left ventricular assist device, or an LVAD, which is a mechanical pump that literally assists the heart in distributing blood. And in extreme cases, someone might have a heart transplant. Alright, as a quick recap. Dilated cardiomyopathy is a disease of the myocardium which causes all four chambers of the heart to get bigger. Because heart walls will be thin compared to the large chambers, this can result in weak contraction, low stroke volume, and congestive heart failure. It can also cause valve regurgitation and arrhythmias. Treatment, in extreme cases, is to do a heart transplant. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Aman is a 60-year-old male who came into the clinic with shortness of breath and lower limb edema for the past 3 months. He has a history of hypertension, hyperlipidemia, and chronic alcohol use. On auscultation, an additional S3 sound is heard. An echocardiogram is performed. which shows dilated ventricular chambers and a reduced ejection fraction. Alexandra is a 23-year-old professional volleyball player who came into the clinic after multiple episodes of passing out during her games. At first, she presumed it was due to dehydration, but she's now concerned. She has a family history of sudden cardiac death in multiple relatives. An echocardiogram shows asymmetric hypertrophy of the intraventricular septum and a normal ejection fraction. Both Aman and Alexandra have cardiomyopathies. From outside to inside, the heart is made of the epicardium, myocardium, and endocardium. Diseases that affect the myocardium are called cardiomyopathies. The three main subtypes are dilated, hypertrophic, and restrictive cardiomyopathy. Let's start with dilated cardiomyopathy, which is the most common one, accounting for almost 90% of all cases. Now, in dilated cardiomyopathy, the ventricular walls become thin and weak. As a consequence, the ventricular chambers dilate. Because the ventricular wall is thinner, muscle contraction is weaker and the heart can't pump blood efficiently throughout the body. So we have a systolic dysfunction with normal diastole. Okay, when it comes to the etiology of dilated cardiomyopathy, the large majority of cases are idiopathic, meaning the cause can't be identified. However, there are many secondary causes that must be excluded first. Examples include toxins like chronic alcohol or cocaine abuse, nutritional deficiencies like thiamine deficiency, also called beriberi, or selenium deficiency. Another cause is myocarditis, which is inflammation of the heart muscle, usually caused by viruses like Coxsackie-B, but can also be related to autoimmune diseases like lupus. Hemochromatosis is a disorder of iron overload in which excessive iron can be deposited in many organ sites, including the cardiac muscle. Too much intracellular iron can act as a toxic free radical, resulting in cellular damage. Other causes include Chagas disease, a parasitic infection caused by Trypanosoma cruzi, which is transmitted by the kissing bug. A clue on the exam would be someone who recently traveled to South America and also has other clinical features like periorbital swelling, megaesophagus, and megacolon. Also, during pregnancy, the body demands more cardiac output. Sometimes, the heart fails to meet this high demand, and we get something called peripartum cardiomyopathy, which commonly occurs in the last trimester of pregnancy and up to 6 months after delivery. Dilated cardiomyopathy can also result as a side effect of some medications like doxorubicin, a chemotherapeutic agent, or trastuzumab, a monoclonal antibody. Even severe emotional stress can cause a form of dilated cardiomyopathy called Takotsubo cardiomyopathy. This is thought to be related to the disease of catecholamines, which in large amounts can be toxic to the myocardium. Examiners try to get creative when it comes to these causes. For example, a case of breast cancer treated with chemotherapy, after which the individual develops heart failure. This should raise your concern for doxorubicin toxicity. Another example would be an individual with anorexia nervosa who develops heart failure, raising your concern for a nutritional cause like beriberi or selenium deficiency. The next subtype of cardiomyopathy is hypertrophic cardiomyopathy. Unlike dilated cardiomyopathy, the heart muscle thickens in a concentric fashion, which means the cells make more myofibrils, which are stacked on top of one another. Histologically, there's myocyte hypertrophy, but the key is myocardial disarray, which is very high yield. This means that they're disorganized and have bizarre-shaped nuclei. Now, it might seem that the heart getting thicker is a good thing, but the problem with a very thick ventricular wall is that it impairs the ability of the ventricle to relax during diastole, which reduces ventricular filling. In other words, we have diastolic dysfunction, but systole is not impaired. Another feature is that the intraventricular septum gets thicker, particularly on the side of the left ventricle. This asymmetric hypertrophy can obstruct or narrow the aortic outflow tract during systole or ventricular contraction, and this increases blood velocity through the smaller opening and pulls the anterior leaflet of the mitral valve toward the septum, which further obstructs the left ventricular outflow tract. In such a case, we call it hypertrophic obstructive cardiomyopathy, or HOCM. At the same time, that mitral valve doesn't shut all the way. Blood can leak back into the left atrium, called mitral valve regurgitation. Alright, now most cases of hypertrophic cardiomyopathy are familial and are inherited in an autosomal dominant fashion, so family history is an important clue. Mutations commonly affect genes coding for components of the cardiac muscle, such as beta-myosin heavy chain and myosin-binding protein C. Now, a commonly tested cause of hypertrophic cardiomyopathy is Friedreich ataxia. This is a trinucleotide repeat expansion disorder, where the death of myocytes leads to difficulty pumping blood through the heart, which thickens the heart's lower chambers or ventricles, leading to hypertrophic cardiomyopathy. Okay, now in restrictive cardiomyopathy, the heart muscle is stiff, preventing it from relaxing during diastole. So that's another cause of diastolic dysfunction, but systole remains normal. Causes include primary diseases, which are often idiopathic, or secondary systemic diseases. An important primary cause is endomyocardial fibrosis, where excessive collagen tissue is deposited in the heart muscle. Sometimes this disease is associated with an elevated eosinophil count and deposition of eosinophils in the endocardium and myocardium, in which case it would be called Leffler's eosinophilic endocarditis. Now, secondary causes are much more common, with the most common being amyloidosis. Other secondary causes include sarcoidosis, hemochromatosis, and radiation therapy, all of which cause fibrosis of the myocardium. Alright, now regarding clinical presentation. In all three types of cardiomyopathy, over time, the heart may be unable to do its job effectively, leading to heart failure signs and symptoms like fatigue, dyspnea, and swelling of the feet. And because cardiomyopathies affect the cardiac muscle as well as the pacemaker cells that run through the cardiac muscle, they can lead to arrhythmias like atrial fibrillation, ventricular ectopic beats, ventricular tachycardia, or fibrillation, and atrioventricular block. Another high-yield fact is that specifically, hypertrophic obstructive cardiomyopathy is the most common cause of sudden cardiac death in people under 35 years, and is especially more common in athletes due to the development of ventricular arrhythmias. Another thing to bear in mind for hypertrophic obstructive cardiomyopathy is that due to the obstruction of the aortic outflow tract, perfusion of the brain can get low, so individuals can present with syncope, which is a transient loss of consciousness. Diagnosis of cardiomyopathy starts with auscultation. So dilated and restrictive cardiomyopathies cause an S3 heart sound, which is the result of blood rushing and slamming into the dilated ventricular wall during diastole. On the other hand, hypertrophic cardiomyopathy produces S4 sound in the apex of the heart. This sound indicates that the atrium is contracting against a thickened left ventricle. Remember, though, that the S4 sound is not specific for hypertrophic cardiomyopathy and can be present in other diseases that thicken the left ventricle, like hypertension or aortic stenosis. If there's also obstruction, as so in HOCM, a systolic murmur between S1 and S2 may be best heard at the left sternal border. This is often described as crescendo-decrescendo ejection murmur because it gets louder as blood first rushes out and then softer. What you absolutely have to know for your tests is that the intensity of this murmur can change with various maneuvers, depending on how much the outflow tract is obstructed. If the person squats down or does a hand grip maneuver, systemic vascular resistance increases, which makes it harder to eject blood out and increasing afterload. This means that the ventricle has more blood stretching it out, and so it becomes less obstructed, and the murmur becomes less intense. If the person stands upright or does a Valsalva maneuver, venous return decreases, which decreases preload, meaning less blood stretching out the ventricle before ejection. So there's more obstruction and the murmur's intensity increases. Okay, a final point here is that since HOCM is sometimes associated with mitral valve regurgitation, a hollow systolic murmur may be also present, meaning it lasts throughout systole. Then comes the ECG, which is usually abnormal in a variety of different ways because there's significant remodeling of the cardiac muscle in all of the cardiomyopathies. For your exams, just remember that restrictive cardiomyopathy, especially when it's due to amyloidosis, leads to low voltage QRS complexes due to diffuse infiltration of the heart muscle. But diagnosis of cardiomyopathies relies primarily upon echocardiographic evaluation, which makes it possible to measure the thickness of the wall and dimensions of the cavities and the pericardial space, as well as the left ventricular function expressed by the ejection fraction. In dilated cardiomyopathy, the echocardiogram generally shows left ventricle dilation with a normal or decreased wall thickness and a low ejection fraction, since there's diastolic dysfunction. Hypertrophic cardiomyopathy is characterized by increased ventricular wall thickness and a normal ejection fraction in the early stages of the disease, since systole is not impaired. Finally, in restrictive cardiomyopathy, the heart's shape and dimensions tend to be normal, but generally there's a normal ejection fraction. So on the exam, don't exclude a myocardial disease based on a normal ejection fraction. The goal of treatment in cardiomyopathies is aimed at symptom relief and ensuring that the heart continues to function. Another key is to prevent myocardial infarctions and congestive heart failure. For dilated and restrictive cardiomyopathies, this includes treating the associated disorders, such as heart failure with medications like beta blockers and ACE inhibitors, as well as sodium restriction and diuretics for individuals that develop fluid overload and congestive symptoms. Digoxin may also be used, since it helps increase force of contraction. For hypertrophic cardiomyopathy, cessation of high-intensity athletics is recommended to avoid sudden cardiac death. Treating the associated arrhythmias may be done with medications like beta blockers or non-dihydropyridine calcium channel blockers like verapamil. For your exams, it's also important to remember the medications that are contraindicated in case of hypertrophic cardiomyopathy. The concept behind this is that the left ventricular outflow tract obstruction worsens when there's less blood stretching it out. Therefore, medications that decrease venous return or systemic vascular resistance, like dihydropyridine calcium channel blockers, nitroglycerin, and ACE inhibitors, should generally be avoided. Positive inotropic medications like digitalis are also contraindicated, since they tend to increase the force of contraction, which can actually increase the obstruction as blood is being forced out of the ventricle. Additionally, in all cardiomyopathies, those prone to fatal arrhythmias need implanted pacemakers or defibrillators. Finally, some individuals need a left ventricular assist device, or an LVAD, which is a mechanical pump that assists the heart in distributing blood. And in extreme cases, someone might have a heart transplant. Alright, as a quick recap, cardiomyopathies are diseases of the heart muscle and are classified into dilated, hypertrophic, and restrictive cardiomyopathy. Dilated cardiomyopathy is characterized by thin ventricular walls and a reduced ejection fraction. It's mostly idiopathic, but secondary causes include alcohol use, beriberi, and medications like doxorubicin. Hypertrophic cardiomyopathy is characterized by asymmetric hypertrophy of the intraventricular septum and is the most common cause of sudden cardiac death in people under 35, especially athletes. Restrictive cardiomyopathy is the least common and is characterized by ventricular stiffness, which restricts diastole. Causes include primary diseases, like Leffler's endocarditis, or secondary diseases, like amyloidosis. Okay, back to our cases. Aman is presenting with features of dilated heart failure, like shortness of breath and lower limb edema. Considering he has a history of chronic alcohol use and his echocardiogram shows dilated ventricular chambers, the diagnosis of dilated cardiomyopathy is confirmed. Alexandra presented with multiple syncopal episodes. Her family history of sudden cardiac death is certainly concerning. Alexandra's echocardiogram shows asymmetric hypertrophy of the intraventricular septum, a key feature of hypertrophic obstructive cardiomyopathy, or HOCM.
Cardiomyopathy translates to heart muscle disease. So cardiomyopathy is a broad term used to describe a variety of issues that result from disease of the myocardium, or heart muscle. When cardiomyopathy develops as a way to compensate for some other underlying disease like hypertension or valve diseases, it's called secondary cardiomyopathy. But when it develops all by itself, it's called primary cardiomyopathy. Now, hypertrophic cardiomyopathy is when the walls get thick, heavy, and hypercontractile. Essentially, the muscles grow a lot larger because new sarcomeres are added in parallel to existing ones. Usually the left ventricle is affected, and in most cases the muscle growth is asymmetrical, meaning that the interventricular septum grows larger relative to the free wall. These larger muscles do two things. One, the walls take up more room, and so less blood can fill into the ventricle. And two, they become more stiff and less compliant, and essentially they can't stretch out as much, again leading to less filling. When they don't fill as much, they don't pump out as much, and stroke volume goes down. So the heart can fail to pump enough blood to the body, called heart failure. And since this is due to a dysfunction in filling, which happens during diastole, this is a type of diastolic heart failure. In some patients, the muscle growth of the interventricular septum essentially gets in the way of the left ventricular outflow tract during systole, or ventricular contraction. And this increases blood velocity through that smaller opening, and that pulls the anterior leaflet of the mitral valve toward the septum, called the Venturi effect, which even further obstructs the left ventricular outflow tract. For this reason, hypertrophic cardiomyopathy is sometimes called hypertrophic obstructive cardiomyopathy. An obstructed left ventricular outflow tract means that blood's forced through a really tiny opening, right? Which tends to cause a crescendo-decrescendo murmur, where it gets louder as blood first rushes out, and then softer. And this is very similar to the murmur in aortic valve stenosis. The intensity of the murmur with hypertrophic cardiomyopathy, though, can change depending on how much the outflow tract is obstructed. If the person squats down or does a hand grip maneuver, systemic vascular resistance increases, which makes it harder to eject blood out and increases afterload, which means that the ventricle has more blood stretching it out, and so it becomes less obstructed, and the murmur becomes less intense. If the person stands upright or does a Valsalva maneuver, though, venous return decreases, which decreases preload, right? Meaning that less blood stretching out the ventricle before ejection, and that obstruction gets larger, which means the murmur's intensity increases. Also, people with obstructive hypertrophic cardiomyopathy might have a bifid pulse, where two pulses are felt, and this is from the mitral valve moving toward the outflow tract and causing increased obstruction mid-systole. So with larger muscle mass, the ventricles become less compliant, which, remember, means that they don't stretch as easily when they fill with blood. If listening on auscultation, often an S4 sound can be heard from the atria contracting and pushing blood into a non-compliant ventricular wall during diastole. And another thing is that those larger muscles need oxygen, right? Like a lot of oxygen. Well, remember that we just talked about how the heart has a harder time getting blood and therefore oxygen to the tissues? Well, without oxygen, this tissue becomes ischemic, and this is thought to be why people with hypertrophic cardiomyopathy sometimes develop dangerously fast arrhythmias, and why hypertrophic cardiomyopathy is the most common cause of sudden death in young individuals, especially young athletes. A little less severe symptoms of hypertrophic cardiomyopathy might be things like dyspnea, which is difficulty breathing, or syncope, which is fainting. Now, the majority of cases of hypertrophic cardiomyopathy are inherited as an autosomal dominant trait, and caused by a genetic missense mutation, where a single nucleotide is swapped, causing a different amino acid to be coded for. This type of mutation usually happens in one of the genes that encode for proteins in the sarcomere of the heart muscle. The beta-myosin heavy chain is the most common, but it can also be mutations in the myosin binding protein C and troponin T. A classic finding on histology is myocyte disarray, where instead of making nice parallel lines, myofibers don't line up quite right. Also, people with Friedreich's ataxia, which is an autosomal recessive neurodegenerative disease, often develop hypertrophic cardiomyopathy. Now, treatment of hypertrophic cardiomyopathy might involve medications like beta blockers, which help slow down the heart rate. If those aren't tolerated well, though, calcium channel blockers like verapamil or diltiazem might be used. Digoxin, however, a medication used occasionally for heart conditions, is contraindicated, since it tends to increase the force of contraction, which can actually increase the obstruction as blood's forced out of the ventricle. Besides pharmacological treatments, some people with hypertrophic cardiomyopathy might have surgery. Alright, as a quick recap. Hypertrophic cardiomyopathy is when the walls of the heart get thick, heavy, and hypercontractile. It usually affects the left ventricle, causing symptoms like a lower stroke volume, an obstructed left ventricular outflow tract during systole, a variable crescendo-decrescendo murmur, a bifid pulse, and dangerously fast arrhythmias. It's most commonly caused by a genetic mutation affecting proteins in the sarcomere of heart muscle. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Cardiomyopathy translates to heart muscle disease. So cardiomyopathy is a broad term used to describe a variety of issues that result from disease of the myocardium, or heart muscle. When cardiomyopathy develops as a way to compensate for some other underlying disease like hypertension or valve diseases, it's called secondary cardiomyopathy. But when it develops all by itself, it's called a primary cardiomyopathy. Restrictive cardiomyopathy is where the heart muscle is restricted, meaning it becomes stiffer and less compliant. The muscles and size of the ventricles, though, stay about the same, or maybe they only get slightly enlarged. Normally, when blood fills into the ventricles, they're compliant, so they stretch out and allow more blood to fill in. When blood fills into restricted ventricles, though, they aren't allowed to expand. So stiffer, less compliant ventricles means that the ventricles can't stretch, and less blood fills into the ventricle, which means the heart starts to fail to pump out enough blood to the body. So restrictive cardiomyopathy causes heart failure, and since filling happens during diastole, we say this is a type of diastolic heart failure. Now, several mechanisms can lead to stiffer heart muscles and restrictive cardiomyopathies. One of these is amyloidosis. Amyloids are proteins that have been misfolded, and once misfolded, they become insoluble and can deposit in various tissues and organs, making them less compliant. Familial amyloid cardiomyopathy is a genetic disorder where mutant transthyretin protein, or TTR, is misfolded and prone to depositing in the heart tissue. TTR is a protein that usually circulates in the blood and helps transport thyroxine and retinol. And mutations in TTR are more common in African Americans. Similarly, senile cardiac amyloidosis is where, over time, wild-type or normal TTR deposits in the heart, and this is typically seen in the elderly. Sarcoidosis is another cause that involves the formation of granulomas in the heart tissue, which are these collections of immune cells. Yet another is endocardial fibroelastosis, where fibrosis develops in the endocardium, the inner lining of the heart, as well as the subendocardium right under, again making the tissue less compliant. Endocardial fibroelastosis happens most often in children, and is thought to be caused by a variety of diseases and stresses, like infections and even nutritional deficiencies. Leffler syndrome, where eosinophils accumulate in the lung tissue, can also affect the heart tissue, called Leffler endocarditis, or sometimes Leffler endomyocarditis. In this case, eosinophils accumulate in the endocardial layer of the heart tissue, causing inflammation and endocardial fibrosis, making it stiffer and again less compliant. Also, with hemochromatosis or iron overload, iron can deposit in the heart tissue, which contributes to restricted ventricular filling. Finally, radiation of the heart tissue can also lead to restrictive cardiomyopathy, and it's thought that this is because radiation generates reactive oxygen species in the tissue, which ultimately leads to inflammation over time and causes myocardial fibrosis, or fibrosis of the heart muscle tissue, which makes the tissue stiffer and more restrictive. For diagnosis, sometimes an electrocardiogram, or ECG, can be helpful, and these people will often have low amplitude signals and smaller QRS complexes, due to restricted ventricular contraction. The treatment for restrictive cardiomyopathy will be to treat the underlying cause, if possible. For example, treating hemochromatosis by removing excess iron. In a lot of cases, though, the definitive treatment is heart transplant. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.